Thank you very much. I think we'll open it up now to questions from the audience, and please to the investigators or to the panelists. Yes, please, and introduce yourself.
François Raffi from France. Thank you for a very nice presentation. I think the results are very important and one of the most important in the past few years. I have a small comment and two short questions. The comment is when the title of New England says that there is a need to initiate treatment at early asymptomatic infection, I think the results of START clearly show that below 350 is too late, rather than early is better, because we don't know for sure that treating above 500 or at 500 makes a difference based on your results. And clearly the threshold, of course, it doesn't make any change for me for clinical practice, but clearly looking
Can you just get to the questions, please?
And my questions relate to the fact that even for eye patients above 800, you still have events. Clearly, 800 is still a CD4 level which is abnormal. Normal level in HIV negative population is above 1,000. So did you look at patients with normal CD4 levels if they have any events above 900 or 1,000?
Thank you.
And also for the suicide, were the most common events leading to death. Were this related to efavirenz?
Okay, thank you very much. I would urge the people who are asking questions to make them very short so that we can get as many as possible. Yes, please, Jens.
So this is the slide that addresses your question, Francois, so I'm sorry that you missed it. So most of the follow-up time was spent above 500. And therefore, there is no upper limit in the study that we identified above which there is not a need to give treatment, which is why the recommendations are. In terms of the suicides, just to reiterate that the suicidal and self-injurious behavior was similar in the two arms. There were 3 cases of death with completed suicides. All of them occurred in the deferred arm in people who was not taking the efavirenz. Thank you.
Yes, please.
Trip Gulick from New York. Jens, congratulations on this presentation. In your discussion of safety, you focused on grade 4 clinical events. Could you talk about lower grade clinical events like grade 2 and 3? And also, what about laboratory events, particularly renal function in the 2 groups?
So I'll start the response to this. Can you hear me okay?
Yes, please speak up a little bit higher.
Trip, we did not systematically collect kind of lower grade events kind of throughout the trial. We focused on grade 4 events because of the size of the trial and because obviously of their severity. We do have laboratory measurements that were recorded every year that we'll report subsequently in a later report. No evidence there from kind of our initial look that there's any kind of differences which are important. We also did a study on quality of life that will be separately reported, which I think is consistent with these overall results. And so, but in terms of the lower grade abnormalities kind of that were reported kind of that were not queried, we did not collect those.
Thank you. Yes.
Gustavo Lopardo, Argentina. Jens, thank you for your nice presentation. You showed that 96 events developed in the deferred group. Could you comment on what percentage of these patients were on an antiretroviral therapy when they developed the event?
Sure. Anybody? So it was around, I can just give it, it was around 25% of the participants had started on treatment in advance of being diagnosed with the event. It is, however, important to note that this is probably a conservative estimate because we can see that some of those who started on treatment started it relatively soon before the event was diagnosed, and therefore the sense is probably that some of those initiations were driven by people who were deteriorating clinically and was picked up by their physicians. So it's probably below 25, which was the real number. So in other words, most of the events that occurred in the deferred arm was happening in people as they were left untreated.
Thank you. Yes.
Peter Hunt from San Francisco. Congratulations to the team on a really terrific study. I'm wondering, are there plans for longer-term follow-up of these individuals? They could potentially inform the immune activation agenda if, in fact, there's a lower inflammatory set point in people who started earlier.
Very good point you raised. The DSMB, when they recommended unblinding of the results, one of their strong recommendations was to continue follow-up, even though we hope almost all of the participants in the deferred group will be starting antiretroviral therapy, because it's still going to address an important question. We're going to have a very large cohort in which half of them have started with a CD4 of 650, and the other half, even if all of them started now, there would be a difference of about 100, 150 cells between them. So it was quite important to look at the longer term follow-up for that. The other reason is that the average follow-up in the start is about 3 years, and it's a very short time compared to a treatment we're going to take throughout life. And so that is the other importance of it. The study is continuing, and that's why in the recommendation that the trial was not stopped, but is continuing follow-up. At the moment, we're continuing follow-up until the originally planned follow-up, which is the end of 2016. But, we'll be thinking about even longer-term follow-up.
Thank you. Yes, go ahead, and then we'll come to this side. Yes.
Yeah. Pedro Can, Argentina. I would like to know if you have the median CD4 at which the AIDS-related and non-AIDS-related serious event happened in both groups, because maybe you showed it, but I missed it.
Okay. So just to say that it's really to belabor on the point that these events occurred in people when they had a CD4 cell count above 500 in most parts. So therefore, the median CD4 when the events were happening is in the deferred arm around 550 and around 200 cells more in the immediate arm, which essentially is explained by the fact that the two cohorts of patients lived with a CD4 cell count difference around 200. So again, the START study is really addressing the point of whether there is a benefit in people who lives their lives with a CD4 more than 500. And indeed, as I showed on this slide here, because I want to make sure that people really understand this, that the rate of the primary event was 0.6 per 100 person-years in the median arm, as opposed to 1.1 in the deferred arm, consistent with the overall result.
Thank you. Let's go to this microphone. Yes, please, go ahead.
Marcelo Wolf from Chile, from a site participating in the START study. I would like to know if there was any difference between those who started therapy below 350 and the group that started from 350 and 499 compared with those who started with above 500?
Okay, so let me just, I need to spend more time on explaining this slide then, because that's where the data is. So in the deferred arm, there was 5 events in people with the latest CD4 of less than 350, giving a rate of 1.8 per 100 person-years. Among people who lived with the latest CD4 between 350 and 500, there was 34 events in the deferred arm with a rate of 2.0. In people who lived between 500 and 650, 34 events and a rate of 1.5. There was 9 in patients who lived between 650 and 800, giving a rate of 0.6. And then in people who lived with a CD4 of more than 800, there was 14 events and a rate of 1.1. Thank you.
Thank you.
Let's go back, please.
Sharon Walmsley from Canada. I add my congratulations to the team. I have 2 questions. What was the recommendation for prophylaxis against either tuberculosis or PCP? And secondly, I didn't notice how many people switched from the deferred group to treatment because of pregnancy.
Anybody want to say? I'm bringing up the slide with the treatment. So this gives you the proportion of treatment, the number of people who used anti-TB medication at baseline or during follow-up or at follow-up only. So yeah, so you can see these
That's
numbers.
treatment or prophylaxis?
This is a combination of treatment and prophylaxis. So you can see it's less than 40 in the deferred group. In terms of people who are using medications that could be protective against PCP, it's 114 and 1 in 76. And some bono information also, we have statin use. So fairly low numbers, as one would expect probably given the high CD4 cell count that people lived at.
So it was not mandated by your protocol?
There was no mandation of this. Maybe I can bring in Fred Gordon,
Right.
that obviously
So
is...
We left it to local guidelines and local standard of care in terms of prophylaxis. The second part of your question, the answer is 46 people started ART because of pregnancy or breastfeeding.
Thank you. Yes.
David Maman from France. For this slide, the previous slide on incidence above 500 with the latest CD4 count, can you say if this difference was significant and what was the p-value in the difference? It's not written.
I'll turn to my statistical colleagues to respond to that.
So this analysis is meant to be descriptive, and there's clearly a lot of further work on this which is necessary. I mean, these comparisons between the immediate and deferred are not protected by randomization, and so we put this here primarily for illustration to show that basically events that occurred in this trial in both groups occurred at higher levels, and in the immediate group they were taking ART. And that, as Jens indicated, that poses some additional research questions for us that we've been thinking about. But at this point, I don't think one should kind of make too much of the significance of the treatment differences because these are not protected by randomization.
Yes.
Anna Berstein, Institute for Disease Modeling in Seattle. Why do you think there were so many more events in the trial that had been predicted when the trial was first powered?
That was not the case.
Well, ARP can do that. I should say that our Barbaker is the one who actually designed the study, so ARP.
The rates of the absolute rate of events was actually lower in the study than predicted. We predicted the benefit from early treatment, which we projected, was less than we've actually observed. So what we've observed from the data is actually larger benefit, larger reduction, but the event rate themselves in terms of were actually lower than we predicted, if that makes sense.
Thank you.
Yes.
And this was despite the fact that the CD4 in the deferred arm, when people were starting on treatment, was actually higher than what was predicted when the model of the sample size was calculated. So it's obviously giving you a very robust result, essentially. Thank you.
Yes.
Alison Alga from Johns Hopkins in Baltimore. Just a quick question. I noticed that there were quite a few that were suppressed even before you started with really low viral loads, with raising the suggestion that there may be some elite suppressors maybe in there. Wondering if you would care to go on a limb and say this recommendation would go along to apply to elite suppressors as well in terms of starting everybody. Curious what the study thought.
Anyone wants to take that? There was around 400 people that entered the trial with the HIV RNA that was low, as you say. We actually published a couple of months ago in HIV Medicine a article specifically focusing on that subgroup of START, and if I can refer you to that. In terms of the second component of your question, which relates to the subgroup analysis that I showed you, and maybe I can bring in Arp or Jim into this, just to reiterate that the benefit that favors immediate treatment was evident irrespective of the viral load at study entry. So Arp, huh? And the next slide after that. Fred, you want to give a comment? Huh?
I think the answer to the question is that there's no evidence that the level of viral load kind of influenced the relative risk difference that we saw. Obviously, as Jens mentioned, the rate was lower among those with viral loads. So therefore, as a consequence, the absolute risk difference is smaller for those who came in with lower viral loads as well as lower CD4 cell counts than higher levels, or higher CD4 cell counts than, as well as those with lower kind of viral loads. But it's the relative risk differences were similar.
Yes.
Ricky Sue from NYU and the United States. It seems like most of the benefits were driven by patients who developed bacterial infections such as tuberculosis and PCP, as well as cancers such as lymphoma and Kaposi sarcoma. There obviously is a cost-benefit ratio regarding treating patients versus not treating patients. So some of these issues that might have been already brought up by Sharon Walmsley and so on and so forth, a lot of these endpoints could be screened for. So, for example, tuberculosis with PPD testing, quantiferon golds, and doing INH prophylaxis, the Kaposi sarcoma with HHV8 screening, and lymphomas with Epstein-Barr virus screening. If you factored out these main drivers in terms of event rates, would you still see a significant difference in terms of overall event rates in the patients who started treatment early versus delayed?
Go ahead.
If I could just start by saying I'm not aware of any screening method that can detect and treat people at risk of lymphoma and Kaposi sarcoma. There is not such a screening test available, I have to say. Nor is there any screening test that identify people with this smear of cancer events that I showed you down here that occurred around twice as frequently in the deferred arm. So I think what we are looking at here, and in terms of TB, and maybe Fred can come in on this, but it is a challenge to prevent TB biomedically at least. But I think, and Fred, I can bring you in here, but I think what is really important here is to appreciate that this means that there's a hole in the immune system, right? And of course you can argue the event rate is low, as you correctly say, and therefore you need to treat relatively many people for those that would benefit. The problem is that we actually don't have a test that can identify that deficiency. So it's a sort of a game that you're playing in terms of whether you want to develop these diseases or not. But coming back
well, I would just agree with Jens. I mean, clinically speaking and practically speaking, I mean, there is no way to identify and protect against each sub-illness that's being identified here. In terms of tuberculosis, the TB events were not occurring close to randomization. This was not a factor of missing TB at entry. Some of the individuals had received INH, some had not. Other studies that have been done have shown INH maybe counterintuitively or maybe because of the spread of TB in the local region is not protective unless given indefinitely. So I would say the results speak for themselves, that there's no way to pull out individual patients at this point in time. Whether 10 years from now somebody can do that, maybe can refine it to that, may be the case.
Okay, let's get the last question. Yes, please.
Yeah, hi, Jens, Joe, you're on. Just a quick question. Did you get the data to collect CD4, CD8 ratio?
Yeah.
That may be one of your predictors.
We did, actually. Thank you for that question, Joe. So anybody wants to, I'm happy to say that Abdul Babakar is going to have a lot of fun with the CD4 to CD8 ratio data in a follow-up publication. But Ab, you want to share your thoughts?
Well, no, nothing. But one of the slides, and one of the main actually conclusions from the study is how poorly the CD4 does in predicting what is going to happen. So, which highlights the need for searching for other markers other than the CD4. What we'll be doing, I think, we'll be looking at the data a bit more closely and see what markers are going to predict those small number of patients who are going to develop clinical events, and that will include CD4 over CD8 ratio. Can I just add one thing, because there was a question about the very low event rate, which I think was raised by, which is quite correct. We expected a very low event rate in this patient population with very high CD4 count. And the importance of the study was try and look at the balance between the risk and benefit. If you look at some of the slides Jens have shown, there are about probably 4 or 5 times, if we look at just the number of clinical grade 4 events and hospitalization. And that was the balance. But if we even just focused on the primary endpoint, even though the absolute difference is small, it does not mean that this intervention is not going to be cost effective, because you've got to factor other benefits of early treatment into account. And one of them, obviously, the prevention of transmission of HIV by people who are taking antiretroviral therapy and having suppressed viral load.
If I could just add that the reason why we're not showing the subgroup analysis according to the CD4 to CD8 ratio was the fact that it was not pre-specified. So that's why we have not this is not part of the presentation today, but we will certainly make sure that it's communicated in due course.
Can I just maybe ask the question of the panelists as well as the researchers? This has been the question of the START study in Temprano has been a very fundamental, pivotal question in HIV treatment. And I'm curious what people think is the next big question in treatment. What is the next big question that we as a global community should be thinking about that would help us advance the science of treatment? So,
long-acting ARTs.
great, thank you. Other suggestions from our panelists?
No, I think the issue around how does one identify those patients with immune dysfunction, and we're seeing the CD4 count is really not a good predictor.
It's
so
a
I think
partial
the next step
prediction, yeah.
is going to be that.
Others, Gottfried?
In addition to what's already been said, of course, service delivery approach is how best to get the services to the people.
I mean, what's very impressive in both START as well as HPTN 052 is the people who initiate treatment, it's remarkable the viral suppression rates that they achieve. And I think what's going to be very critical is in our programs, and the scale-up is just going to be not only important to start people on ART, but to be able to maintain viral suppression, because without that, it's unlikely that these benefits will be achieved for either the individual or for transmission. Do you want anyone else on the panel wants to comment on the big question, the next big question?
I think it's been said really, delivery modalities, really looking at longer lasting treatment, but also just going back to the issue of the tolerability of treatment, because even some of the first line combinations that we're using now, I know from experience, can not always be easy.
How about from the investigators, the next big question in treatment?
So, I mean, I think we have resolved when to start treatment. So I think the next big challenge is that as people are aging, the serious non-AIDS events that we are looking at will become a huge medical problem. And I don't think we have the correct arsenal of medical interventions to deal with that, in particular cancers and cardiovascular disease. So I think that's where we need to refocus our efforts to be very innovative in which intervention modules to consider and do appropriate clinical endpoint-driven research to clarify which of those are effective.
Others? Any other comments? The next big question?
Give us a chance to digest it a little bit more.
We'll give you an hour, or maybe overnight. So I want to end the session by, first of all, thanking the researchers for these remarkable findings. It's not easy to conduct such a study, and I think it's, for all the participants and all the sites that participated, we need to congratulate them for their efforts. And I want to also thank, of course, our panelists, and thank you all for attending today. Thank you.